So there's no doubt we've made some progress on patient safety in the United States and indeed globally. The progress has been made. It's 12 months now since Free from Harm, the National Patient Safety Foundation report, was published at or around the time of this meeting last year, and it recognised that some progress has been made. My feeling, however, is that we've probably done as much as we're going to do if we think about safety as a series of projects. So let's tackle hospital-acquired infections, or let's tackle pressure ulcers, or let's tackle sepsis. We've probably gone as far as we can thinking with that kind of mindset, and so now we need to be focused on how do we create systems of safety? How do we learn from the learning in those projects, but in a systematic way? And I suspect those safety systems will have two main domains or dimensions. The first will be that learning system. So how do we measure stuff differently? My colleague Carol Harridan talks about this, I think, in a very compelling way. She says at the moment we measure the number of times people fall through the ice. What we should be doing is monitoring the thickness of the ice. So it's moving to proactivity and away from reactivity as we think about new systems. Second thing I think we need to do in the new approach to safety is much more actively involve patients in patient safety. The person who has the biggest stake in patient safety is the patient themselves. And I think there's a conversation we could have with patients about getting involved in patient safety, and that's something IHI I think would like to actively promote. Then I think there is something too about how we think about what is safety. So firstly, my first concern there is let's move away from seeing safety just as the prevention or elimination of harm, important as that is, and start to think about it as how do we make more things go right. So instead of thinking about how do we make fewer things go wrong, how do we make more things go right? How do we look at the whole curve of performance and not just at the failures? Learn from our successes as well as learning from our failure. Then I think we need to be very focused on our definition of what is harm. And I've been fortunate enough recently to look at some work where people are seeing absence of dignity as harmful to patients. And I think if you ask patients, was this harmful? Did this feel harmful to you? They would say yes, it does. And so can we give that a prominence that's just as great as the prominence we give to reducing physical harm? Can we look at reducing the emotional harm that patients suffer?